Good morning, everyone. Welcome to the Pediatric Readiness Program's February 2022 education session. Today's session is presented by Dr. Horowitz, Associate Medical Director of the Oregon-Alaska Poison Center at Oregon Health and Science University. Please feel free to enter your questions into the chat throughout the presentation, and we will leave time for questions at the end. And with that, I will turn it over to Dr. Horowitz.
Well, hello, and thank you to everybody who is joining us. I'm going to talk today about things that can turn you various shades of blue. These are mostly pharmaceuticals and chemicals, and I tried to focus it on things that were real cases that were pediatric related. There's always a long list of those drugs, but we're going to focus on just three items. So for those of you who want to claim CME for today, if you point your phone at that little QR code, you can go ahead and claim that. I'll bring that back up again at the end in case anyone misses it here at the beginning, and in case anyone joins us late. There's also a website you can go to if you don't have a phone at your side, which would be unusual nowadays. Thank the Pediatric Readiness Program for inviting me to talk today. And we're talking about methemoglobinemia, which is one of those long mouthful kind of words, but we're going to go through it and explain how that can occur. So my objective for all of you is to learn about it, learn about the diagnostic testings, the thresholds to treat, what those treatments are, and what the contraindication to the main treatment, methylene blue, is. I have nothing to disclose, and this is all unbiased. So first case I want to talk about is what I call, I can't believe it's not toothpaste. We go to a medical conference, usually about once a year, and they have a poster hall full of variety of cases and case reviews. And one of my favorite ones from decades ago was a review from the California Poison Center about this time that the ads for I can't believe it's not butter were coming out. They looked at things that people called the Poison Center that they brushed their teeth with and then said, I can't believe this is not toothpaste. So this is one of those. This is a mother calls up and sent into the hospital. She says her daughter had brushed her teeth with teething gel a little earlier, a couple hours ago. She originally looked fine and rinsed her mouth out, but now she looks a little gray blue in color, which is quite concerning to the mother, of course. Here are the items from that poster. Things that come in a tube that might be left in the bathroom sink. You could have high fluoride toothpaste, which sometimes could be a problem, but generally not. Steroid creams, fungal creams, spermicides, liniments like methyl salicylate, which if you take enough of can cause salicylism. But teething gels are one of them, and certainly are used quite frequently over the counter. Unfortunately, sometimes the brand name on these don't help. For instance, Orajel, who makes both a teething gel pictured there on the left, at least my left, and they also make a anti-cavity fluoride toothpaste with the same brand name. So you can see how easy it would be to confuse these two. The teething gels, of course, have benzocaine in it. So this young girl looked ashen, but she was awake. I was really not particularly ill or bothered by her appearance. Her pulse oximetry is 85%. They put oxygen on her, does not change. Her vital signs are normal, maybe borderline tachycardic for her age. Respiratory rate's 38, maybe a little bit elevated. But her heart and lung exam is completely benign. The skin is gray blue, and she's completely neurologically intact. So this is a picture from a different poster because we didn't take pictures of the original case, but this is kind of what someone with methemoglobinemia, or at least a child with methemoglobinemia, might look like. And the blue, as often described in the literature, is kind of a relatively speaking. You can see compared to the examiner's hand there, which looks pinkish, that the child looks more dusky in colored. So before we go any further, I want to explain how pulse oximeters work. First of all, nowadays, you can get these for home. I'll just show you one that I bought years ago when I was hiking at altitude just to see how desaturated I got. You just kind of push the button, put your finger in it, turn it on, and it'll give you a readout of your pulse and your saturation. Now, thankfully, mine's in the 90s. These are inexpensive. I'm not saying for telling people to go out, but I know during COVID time, some of these have been given out for home monitoring. But the way they work is interesting. They basically take 2 infrared wavelengths of light and they shoot it through the fingertip to a detector that's on the other side. And these 2 wavelengths are absorbed differently, and the absorption depends on the amount of hemoglobin that's saturated. And so the saturation is what's measured. Unfortunately, when you have an abnormal hemoglobin, this throws the entire algorithm off. And often the saturation goes to the mid 80s, like 85 to 87% typically, and it stays there no matter what you do. You cannot make the infrared lights change or read that algorithm on the detector any differently. And so I've seen a lot of case reports, and certainly get calls. The patient is hypoxic, the child is hypoxic. I've seen it written up in the literature. And in fact, the child is not hypoxic, meaning they lack or have low oxygen, because if you were to get an arterial blood gas on them, it would be normal, or if they were on oxygen, probably have high PO2s, probably in the 200 range if they were on high flow oxygen. What they are is they have an instrument that is no longer functional given the disease state that has occurred. And so my advice whenever we get these calls is, please, I know it's the 5th vital sign, but just go ahead and take that off, because it's not going to be useful until things have changed and the child has got, or adult has gotten better. Because people just look at it and they feel like they want to do something. I've even read case reports where people were intubated because they, quote, weren't improving despite everything they could do. And that may not be the appropriate response. Now, just parenthetically, there are companies that make a new level of pulse oximetry. It uses 7 different wavelengths. And with the algorithm that does the reading on these, they have the same little finger device, although it does need to be shrouded in a light shielding foil. It can read the oxyhemoglobin, the carbon monoxide or carboxyhemoglobin, the methemoglobin, which is what we care about, and also the deoxyhemoglobin. Those are the 4 states that your hemoglobin can be in, and they should add up to 100%. And this gives you a more accurate picture. I know we have one in our emergency department. It's locked up and infrequently used, but it can be pulled out for sort of non-invasive measurement of both carbon monoxide and methemoglobin. So what does cyanosis mean? Cyanosis, that blue discoloration of the skin, actually has a numerical definition. So remember, your total hemoglobin is about 15 grams per deciliter in a normal healthy person. If 5 grams or a third of it becomes desaturated with deoxyhemoglobin, you will appear cyanotic. That is the numerical definition of cyanosis. However, with methemoglobin, which is an abnormal configuration of hemoglobin, you only need 1.5 grams of methemoglobin for you to appear cyanotic. And part of it is because methemoglobin itself has a bluish hue to it. So a little bit about hemoglobin. It is a tetramer. It's a molecule with 4 equal parts and 4 equal binding sites. Each one is a ferrous site, Fe, in the +2 state. And each one of those can bind oxygen or carbon monoxide or just water molecule can sit there depending on its state. As it binds more and more oxygen, it can deliver more and more oxygen. It's part of the oxygen delivery to our essential tissues like our heart, our brain, and our other tissues. We have a system in our body that'll take any methemoglobin that may occur, and we have slight bits of methemoglobin normally all the time that is being deactivated by two sets of enzymes. There's a variety of things that cause what we call oxidative stress and converts hemoglobin in the iron in the +2 state to methemoglobin, which is essentially iron in the +3 state in each of those tetramer molecules. And these two enzymes that work are cytochrome B5 reductase, which is the most important one, and a smaller contribution made by NADPH, methemoglobin reductase. And in normal folks, most of the time, without any additional medications that may precipitate methemoglobin, that level is less than 2%, usually even less than 1% in the vast majority of patients and people. So here's a little bit of a pictogram of hemoglobin. So here is the hemoglobin with iron in the +2 state binding oxygen. If we change to methemoglobin, we oxidize that Fe+2 to Fe+3, make it more positively charged. And you can do this with things like nitrogen containing molecules and substances. And when that happens, oxygen won't bind in any of those sites and water is substituted in its place. And so you have this bluish discolorated hemoglobin sitting inside red blood cells that is now making your skin look blue at a much lower concentration than if it was deoxygenated in and of itself. So one of the things people always tell you is, well, we'll just put a drop of blood on a piece of gauze and you could put it next to maybe someone else's blood that happens to be normal on a piece of gauze right next to it. Unfortunately, the textbook description of chocolate brown blood, it's not all that chocolatey looking. You can see here's an example. It's more of a darker burgundy looking. I think if maybe you stare at it for a long time, you can convince yourself it's chocolate brown. But you can at least say that it does not look oxygenated and red. And that's usually the trick to making the diagnosis. Here's a picture of somebody with a very high near lethal concentration of methemoglobin. These are in fact spiked blood samples. This is with 72% methemoglobin. People become symptomatic at levels above 10. Someone would be greatly symptomatic at a level of 70. But you can see here, it's first starting to appear to be chocolate in colored. So although this is like the textbook version, it infrequently happens like this. So what are some of the pharmaceutical causes? There's long lists everywhere. I'm going to point out some ones that come up commonly. So a lot of the local anesthetics, specifically benzocaine, which is in many versions of teething gels, will do it. Prilocaine can also do it. It's often not over the counter, but it's often in compounds like EMLA or injected. Lidocaine occasionally can do it, but you'd probably get lidocaine toxic from the altered mental status CNS effects of lidocaine way before you would become methemoglobinemia. The other big one we sometimes see are sulfur drugs and pyridium, more so in maybe teenagers or adults. I'll mention the local anesthetics that we use at times, like benzocaine is in a lot of these sprays to numb up people for sore throats. If you're incising, let's say, a peritonsillar abscess, this may be something you might want to use. It's metabolized to this phenyl hydroxyalamine compound and nitrobenzene. So that nitro is sticking out there. That's going to cause methemoglobin. And prilocaine is also metabolized to another nitrogen containing compound as well. It's present in a 3-part mixture with EMLA cream. You would have to essentially eat the EMLA. I don't think you would absorb enough of it on his skin to start an IV stick with just a single application. But here's what some of these molecules look like, and toxicologists always like looking at chemistry of molecules. Benzocaine's got that nitrogen group hanging out at the bottom of that benzene ring, and then there's another one that we've seen some cases with, just paraphenyl and diamine. This is what's in henna, true henna. We've had a couple of cases where people have used henna tattoos or henna to colorize their hair and have become methemoglobinemia. So several years ago, back around 2012, 2013, there was an FDA warning saying, don't use these over-the-counter teething gels. Don't use benzocaine spray. And I know many hospitals took these away from us, and people were going, why did that happen? What happened to all of that? But in fact, it did help. This is the number of cases called into a statewide poison control center. You can see it was, not a lot, but 10 to 12 a year. And then suddenly, once you've taken that product away, it starts dropping off dramatically, which is good. So what does methemoglobinemia do to us? At low levels, nothing except perhaps give you that bluish discoloration. Levels up to maybe 15% are barely perceptible by most people. Your O2 sat by a pulse oximeter may drop, but it does not mean you are hypoxemic. Cyanosis appears at about a level of 15, about 20%. I think some people would start to become symptomatic, and that's where they would be having trouble breathing or weakness, depending if they're underperfused in their heart or their brain. They may get tachycardic. They'll probably get acidotic at levels above 50. And it's often said that levels above 70 are gravely hypoxic and lack of oxygen delivery at the tissue level and may lead to death. But we've treated several people who've had levels in the 70s and even higher who have survived. So all the symptoms are related to reduced oxygen carrying capacity and therefore reduce oxygen delivery to the tissue level. Cyanosis is not related to the cover of oxyhemoglobin, therefore the patient is not truly hypoxic, because if you put them on oxygen, the PO2, which is the amount of oxygen dissolved in the blood but not carried by hemoglobin, just the partial pressure of oxygen in a liquid, often is normal, if not hyperoxic, truthfully. So the treatment is well established. It's this medication called methylene blue. It's a dye sometimes used for staining in the lab. And the indications for using it are anyone who's symptomatic, certainly, but generally speaking, levels above 30% are our threshold to consider treating, regardless of what's going on with the patient. Clearly, if they have some issues with need for oxygen delivery and they're having trouble breathing or chest pain or EKG changes, lower levels would be used. The dose is 1 or 2 milligrams per kilogram. That's the same dose for adults and children on a milligram per kilogram basis. It comes in a 1% solution, so that works out to a 0.1 milliliter per kilogram. And here you see a typical ampule of methylene blue. Now, there's some tricks about how it works that I need to explain in a little bit of detail. It itself doesn't do the job. It's reduced in the body to leukomethylene blue, which is the actual pharmaceutical product that changes methemoglobin back to hemoglobin. And it's reduced by NADPH and NADPH methemoglobin reductase. Now that's fine for a vast majority of people, but there's a small subgroup of people who have G6PD deficiency who can't make that NADPH. It's essential to make glucomethylene blue from methylene blue. And if you can't make glucomethylene blue, methylene blue itself won't work. In fact, it may be detrimental and may actually cause some problems in itself. So here's a complicated diagram, but I want to start over on the right-hand side and explain why each step going backwards is essential. So in order for the main thing to occur, which is to convert methemoglobin iron +3 to hemoglobin, we need leukomethylene blue. Leukomethylene blue only occurs if methylene blue is converted to leukomethylene blue by that NADPH methemoglobin reductase. That enzyme won't work in the absence of NADPH. You only get NADPH through the glucose to glucose 6-phosphate cycle that generates, that whose main reason for existing is to generate NADPH to make oxidizing agents. So G6PD deficiency doesn't generate NADPH. Without NADPH, the reductase doesn't work. Without the reductase, leukomethylene blue doesn't occur. So the contraindications are relative But in general, if you have a known G6PD deficiency, which most people are unaware of, or profound renal failure, shouldn't use methylene blue. In general, it's well tolerated. A little bit of GI effects, headache, dizziness has occurred, when they looked at people who've received it. But at very high doses, because sometimes people need more than one dose, if you get as many as 7 doses of this, you can start driving the oxidation of hemoglobin back to methemoglobin. So there's a balance there. You have to give the right amount, but not too much. It's a tricky, and you have to essentially measure methemoglobin levels by a co-oximeter in the blood gas lab, which is where it's usually done, not in the chemistry lab. But if you send your venous blood gas to a blood gas lab, you can get them to give you specific numeric methemoglobin levels. So there's also a risk, and we'll address this in the next case, about hemolysis occurring, sometimes at high doses, but sometimes in people who have G6PD deficiency who are unknown at much lower doses. Now, sometimes it doesn't work. Like many of our drugs, there are treatment failures, and that causes us to step back and say, why? So these are the big 4, and as we go down the list, they become more obscure and rare occurrences, and there are a variety of congenital enzymatic deficits. So you may have G6PD deficiency, which is the leading reason for treatment failure, but you may have something called congenital methemoglobinemia, where you actually make an abnormal hemoglobin that is permanently in the methemoglobin level. Most of these patients are described as more blue than sick, because they just have sort of a bluish tinge to them with a low level of methemoglobin all the time. There's hemoglobin M and self-hemoglobin, rare changes to the hemoglobin, and self-hemoglobin, which is tars or a few sulfur-containing drugs. So the classic triad, just to recoup here, is a cyanotic appearance that's usually out of proportion to symptoms, blood that may be burgundy to chocolate brown color, and a pulse oximetry that stubbornly remains at 85% no matter what you do. You need to diagnose it with the arterial blood gas analyzer in your co-oximetry lab, which is not your chemistry lab, but your blood gas lab, which is usually somewhere else in the hospital. And the only thing that really causes a false positive is that rare occurrence of self-hemoglobin from a few sulfur-containing drugs. And I want to stress how exceedingly rare that entity is. So that brings us to the end of the first case. So I want to talk about bluer, or monomistake. This is a bit of an amalgam from cases in literature, and a case we recently heard at a multi-poison center conference. Is a 16-year-old male who had some abdominal pain and nausea for a few weeks, and eventually got worked up and found a mass on CT. Was referred to a tertiary care center. They strongly suspected Burkitt's lymphoma. And his white count was normal, but his uric acid was quite elevated at 11 milligrams per deciliter, and his creatinine was, I'd say, high for a child of even a heavier child at 16. So the treatment for what this is tumor lysis syndrome with high uric acid levels, and I'll explain how this drug resburicase works. As I kind of look through the literature on it, I've seen that many times it's started without a specific tissue diagnosis and without a clear knowledge of what's causing the tumor lysis syndrome. So resburicase is a recombinant form of an enzyme called urate oxidase, which we don't have, but other animal species do. It, like I said, started often on clinical suspicion alone, just based on finding lymphadenopathy and elevated uric acid levels. And it basically, tumor lysis syndrome it's really its only indication. It's the end effect of release from that tumor of nucleic acids, potassium, phosphorus, and cells itself. And typically there's a lab criteria where there's a scoring system, but you usually need a urate greater than 8. Remember, this person's was 11. The phosphorus elevated greater than 4.5, the potassium greater than 6. This person didn't have those two criteria. And the idea is to prevent kidney injury by creating allotonin, and I'll show you that in a diagram, instead of urate crystals, which can precipitate in the kidney. So first, tumor lysis syndrome produces hyperkalemia from the death of the cells. It releases DNA and purines and releases phosphorus, and phosphorus combined with calcium could cause hypocalcemia, and also urate can happen. Then you can get urate nephropathy and calcium phosphate nephropathy. Both of these crystal forms can cause renal failure, and our goal is to prevent renal failure. If you give a drug like allopurinol, which is a gout medicine, that helps prevent further uric acid from being formed. But once you have uric acid formed, the only solution is to stimulate its breakdown to allotonin. Allotonin is a highly water-soluble drug. It doesn't form crystals like urate forms crystals, and it is able to be diluted, because hydration, of course, is important with this syndrome, and eventually excreted. Again, a picture of where allopurinol works, which is higher up. It prevents the generation of uric acid, but once uric acid has occurred, you really have to get below it. Uric acid converts to 5-hydroxyuricate, and then there's a non-enzymatic degradation. That non-enzymatic degradation creates hydrogen peroxide, and that's the problem. Hydrogen peroxide can generate methemoglobinemia in certain people, especially, and almost exclusively those with G6PD deficiency. So back to our teenager, he gets a typical dose for his size, who's a big guy, of 14 milligrams of rasburicase IV. 24 hours later, he too appears that classic ashen gray color, and his saturations are 87%. He's otherwise fine, looks good, as we have seen with other cases of methemoglobinemia. They put him on oxygen, and of course, that doesn't change the saturation by a pulse oximeter. This is actually a case from the literature which this is borrowed from. You can see his methemoglobin level kind of floated around in the 10 range, while his hemoglobin was higher. His methemoglobin level went up as high as 8 and eventually dropped off over a course of about a day and a half. This is after the respiratory case. So the big question is, and a question that this poison center got called on, and we easily could have been called on if we were in their shoes, would you use methylene blue? So this is where genomics comes into play. So we always talk about personalized medicine and pharmacogenomics and toxicogenomics, and this is why it's very important. Respiricase almost exclusively induces methemoglobinemia in G6PD deficient patients. Therefore, methylene blue will not work, right? Remember, in order to methylene blue to work, we need to make leukomethylene blue. In order for leukomethylene blue to be made, we need G6PD to be generating NADPH. So NADPH, methemoglobin reductase, can generate it. So we have a quandary here. There's a drug that usually is effective, but almost by definition, if this phenomenon had occurred in someone who's got respiricase, we've actually made the diagnosis of both methemoglobinemia and G6PD deficiency. So what are our options? Well, one of them is we just watch and wait. Sometimes the right thing to do is to do nothing. Patients, their methemoglobin level is below the threshold to treat. Typical cases in the literature, in fact, have levels below 20, although there are some that have been higher, and there's a few that have been associated with poor outcomes and death, but very few. So don't be persuaded by that saturation monitor again. That 87% is not real. You need to take that off and not use it. And if you watch and wait in a patient, that methemoglobin level will resolve over several days. Some people have suggested using vitamin C, ascorbic acid. The data for this is weak, although it's a vitamin, it's pretty benign. There's a non-enzymatic alternative pathway to reduce methemoglobin that uses vitamin C as its breakdown product. It's low toxicity, it's low cost, and there's a couple of case reports. Certainly seems like a safe thing to do. The other thing which just comes up over and over again in case reports is to just give new red blood cells. There's everything from transfusing a few units all the way up to exchange transfusing that has been recommended. But truthfully, I would reserve it for cases where there's hemolysis. And this is one of those cases where hemolysis often occurs because things that cause oxidant stress can do two things. They can change your hemoglobin to methemoglobin, but they can also disrupt the red blood cell membrane to make it fragile enough so you end up with a fragility problem. And once the red blood cells travel through the spleen, they break up and you get intravascular hemolysis. So oxidant stress is both ends of the spectrum, methemoglobinemia and hemolysis. And what you end up with something called Heinz Body hemolytic anemia that can occur. And this is what, if you like looking at slides of red cells under the microscope, Heinz bodies look at. This is denatured hemoglobin that tends to adhere to the red blood cell wall, those little blue dots there. And like I say, it makes the red blood cell membrane quite fragile and prone to breakage right at that point. And resburicase is somewhat implicated in many, many cases of oxidant stress hemolysis. Well, Monday morning quarterbacking, what could have been done? Well, if you look at the product label, or your pharmacist takes a look at it, advises you that there is a black box warning, and all of these deserve to be read on every drug that we use. But my toxicologist had a little bit here. It basically says to screen high-risk patients for G6PD activity before starting resburicase, and don't give it once you know that they have G6PD. That part seems like common sense, but few people know that they have G6PD. And of course, stop resburicase if methemoglobin occurs. So one may ask, well, if we don't know and we need to crisis, how quickly can we test for it? And how quickly does methemoglobin occur if we were to just watch them in the hospital after giving this drug, which is only available IV? So the first part of the question is, while there are emerging technologies, care slides that answer, in most part, it's a send out lab to a regional laboratory that usually takes a few days or longer to return. So if you really think that tumor lysis syndrome and hyperuricemia is causing a problem, you probably have to start resburicase because that's the key therapy. So if you give a dose, I mean, you certainly start with a smaller dose, but that's not recommended. If you give a dose, usually methemoglobinemia, in the vast majority of cases, if it's going to occur, occurs within a few hours, if not 6 hours. It's almost like everything else we do in toxicology. You can watch something for 6 hours, and if bad things don't happen, you're probably going to be okay. In fact, that rule applies to resburicase as well. These point-of-care tests are being used in countries where there's malaria, which is important for two reasons. One, there's a lot of G6PD in malaria-prone countries. And two, the drugs we use to treat malaria, like permaquine and chloroquine, are frequent methemoglobin inducers. And so they're looking for field tests that can be used in places where drugs that are high methemoglobinemia inducers are used. Now, many of you said G6PD. I remember that in the back of my head from medical school. It had something to do with fava beans, and fava beans make me think of this guy from the movies Hannibal Lecter. But in fact, G6PD, if I might digress for a second, is a gene that's located on the X chromosome. So men are homozygous, and they only need one G6PD allele, making them far more susceptible to this disorder, which is X-linked. Females can randomly inactivate one or the other of their X of a chromosome and result in a mosaicism, and they may have incomplete expression of G6PD deficiency, and there is a grading system for how it's expressed, but generally felt that if it's less than 30% activity, that's usually defined as G6PD. It's pretty common. The worldwide prevalence is about 5%, or 40 million people, but it's higher in some countries, as high as 25% in certain areas, and it tends to be in places where malaria once was. There's a thought that perhaps it was somehow protective of infection with certain types of malaria organisms. Here's a map generated by a group of investigators showing the prevalence of countries. Now, you can say, well, I guess if someone's heritage is from one of those places, you should test them. Unfortunately, that doesn't leave many parts of the world untouched. And in fact, there have been cases of people surprisingly from Northern Europe and places like that that seem to be free of G6PD where episodic cases occur. But I think clearly in the US, the prevalence is a few percentage, up to 2% perhaps, that it's maybe worthwhile testing, especially on a drug that's as high risk as respiricase of inducing it. Basically, what does G6PD do? It generates that NADPH that we so vitally need to make both nucleotides and to relieve oxidant stress. So what happened in the outcome of this case? Fortunately, but paradoxically, the biopsy actually showed the mass to be lymph nodes consistent with mononucleosis. The methemoglobinemia resolved spontaneously, although the patient actually got a couple units of packed red cells. Not completely clear if that was actually needed, but it was okay. With the single dose of respiricase, the uric acid dropped to an exceedingly low level, suggesting even a small dose of respiricase may be effective in hyperuricemia. Now, the problem is this patient should be considered G6PD deficient, but you need to wait several months to test for it because why? You just gave them a bunch of red cells, which probably have normal levels, or statistically 98% of the time in the US will have normal levels of G6PD in them. So until you have complete turnover and the patient's making their own red blood cells, which often takes 120 days, that's the time you have to wait. And this child should be considered G6PD deficient until accurate testing shows that they are. The outcome in almost all of these cases that have been published in the literature, people who have received respiricase, is close to 99% of them turn out to be G6PD deficient if they develop methemoglobinemia. Here's a list of one of the articles in the literature. I'll cite that at the end, of both adults and children who have had a variety of different diagnoses. You can see this 12-month-old and a 12-year-old and a 6-month-old, year-old people, but there's also older people that had a variety of backgrounds from African American to Cambodian, but also other places around the globe. Their diagnosis varied from ALL, Burkitt's, myeloma, and you can see their peak methemoglobin levels generally were less than 20, although some of them came pretty close to that number. And you can see the dose of respiricase, variety of them had, which in this person received the same dose by milligram per kilogram basis as these other cases. So this is a risk, something that perhaps you hadn't heard before, but put in the back of your mind, this person certainly could have received respiricase in a setting and show up in your clinic as a pediatrician or your emergency department and appear ashen blue. So something to think of in the differential of cyanosis. The last case is one that I think a lot of people around here have been talking about because it happened here. It's a very sad case, but points out some of the risks of the internet more than anything else. There's a teenager who bought and wanted to commit suicide with a tablespoon full of something called sodium nitrite. It's used to preserve food, to cure ham and meats and bacon. And while she was still awake and conscious, she did this in front of a friend, and they called 911 essentially immediately as soon as the person took this nitrate. EMS got there. They had called the poison center, and they sort of said, "What is this, and what's it going to do?" The patient was initially responding to commands. Then she started having sort of like seizure-like activity. Her pupils were equal. She started foaming at the mouth. She got profoundly cyanotic, including perioral cyanosis. Her saturations dropped as low as 74%. She was actually hypotensive, but not tachycardic. And so she got intubated, which is the appropriate thing to do in this particular case. This is a timeline of the events. This case has actually been published, so I think we're free to talk about it. 911 was called about 3:16 in the afternoon. EMS got there within minutes. Poison center was contacted like simultaneously. Within about 10 minutes or less, the patient got intubated and then transported. Cardiovascular event en route. I had push dose epi given and then lost pulses pretty quickly and went to CPR. They went through regular ACLS with multiple doses of epi and chest compression in the emergency room because the poison center had told them just to start giving methylene blue. You're supposed to only give it like once an hour. We said you can accelerate that timetable because this is going to be a severe case of methemoglobinemia. Got 1, 2, 3 doses of it. And then unfortunately, after an hour of aggressive care, which also included transfusion O-negative blood to units of red blood cells to try to give her fresh red blood cells that were not in the methemoglobin state, she deteriorated to asystole and could not be resuscitated. So what are some of the chemical causes and why is this being used? We mentioned that the nitrogen is sort of the key to a lot of this. And so a lot of nitrites and nitrates are some of the chemical causes. Amyl nitrate is something that's in our old-fashioned cyanide kits, which are usually not around anymore. Butyl nitrite is what's called a popper or something that's sometimes sold in head shops and alternative stores to quote, get high with. It probably doesn't do that except if hypoxemia is what makes you high. That's usually the mechanism of that. And then there's sodium nitrite, which is available in meat curing products, easily available over the internet. Unfortunately, you can do a Google search and search on a variety of stores on the internet and easily find this. There's been an incidence of this happening in the last several years. This is since 2017. Increase in mortality and intentional use of this. Poison centers has this become a popular quote suicide tool. You can see the numbers have gone up in the last few years. And it's not just here in the United States. There's a similar study published out of Canada looking at their numbers as well. The number of methemoglobinemia deaths by year from this substance have gone from essentially non-existent pre-2017 when this suddenly showed up on the internet all the way up to the last year where as much as 14 cases in Canada, which is a lot. Just recently, back in early December, the New York Times had an expose on this called When Despairing, You Can Go on the Internet and Learn Ways to Die. It talked about how young people are looking this stuff up and this is easy to be found, and it's a major problem, and people have called on these websites to take this stuff down, but unfortunately, this is a very hard thing to police and control. I want to make people aware of it because it's unfortunately, it doesn't take much to be fatal, but what would you do if you had a case of this that happened to you or heard a 911 calls? First of all, give us a call. We'd like to be involved. I mean the Poison Center, the Oregon Poison Center. In this case, they did. We were able to talk to the receiving hospital. We were able to get methylene blue into the emergency room before the patient arrived. We talked about the option of maybe giving red cells, so they were able to get that rolling as well. We also talked about not worrying about the usual interval of dosing methylene blue, but give it every 5 minutes. Took a little bit longer between doses for that, but I think it could be accelerated as much as that. And to start red blood cell transfusions, and if need be, if the patient is resuscitated, to consider exchange transfusion and to consider using the CPR ACLS for an hour or more until all of this can be done to see what would happen, see if perhaps this could be resuscitated. Unfortunately, it doesn't take very much. Obviously, a tablespoon is lethal and probably even smaller amounts of lethal. It's a very, very difficult problem to treat. Here are some of my references. I looked through a lot of articles and our experiences to do it, but if you wanted to read one article on each of these three cases, these are probably the ones to pick. First is about a case of methemoglobinemia linked to gel-type topical benzocaine, which is a case report. The next one is a case report in a pediatric patient, a case series literature review, as case. A little harder to find, the Journal of Oncology and Pharmacy Practice, but it's there. And the last one, of course, is our article. Lead author is Dr. Meth. It was something we wrote up with our EMS folks and our folks at our community hospital who participated in the care and the poison center. There's a fatal sodium nitrite poisoning kind of information for pre-hospital providers out in pre-hospital emergency care. So those are out there, and I'm willing at this point to take any questions. I will remind you that the Poison Center is available 24 hours a day. There's our toll-free number. You can ask to speak to a medical toxicologist after talking to our poison information specialists, who are both nurses and pharmacists who are highly trained in giving advice. But we're happy to talk to you person to person as a healthcare provider and working with these complicated, maybe even not so complicated cases to give you appropriate advice. Once again, for those who joined us late or those who missed the QR code, it's there. You can point your cell phone at it, little camera, take a picture, and go ahead and get C credits for today's presentation. So I am going to go back to look at the chat room and go back with Rachel, who let me know if there's any questions that I missed.
We do have a couple of questions, I think. The first one is for methemoglobinemia. Can you use venous blood gas rather than arterial for a blood gas? It is more routinely obtained in especially younger kids.
Yes, absolutely. I mean, you don't need to, there's no difference on the arterial or venous side of the abnormal hemoglobin. So yes, as you're drawing up your typical group of starting an IV and a group of tubes, just have a blood gas syringe nearby for the last or first draw through that tube, and you can send it off to the blood gas lab. Venous is perfect. In fact, that's what we advise. You do not need an arterial blood gas, but the lab that runs the arterial blood gases is the lab you want to send it to, and not send it down with the rest of the chemistries.
Thank you. Another question. Never having ordered methylene blue, is this readily available in most EDs, or do they have to send it over from the medical school?
You know, the Poison Center used to do a call around once a year with a list of about 10 to 12 what we'd call essential antidotes. And, you know, and some of these were more exotic than others. Methylene blue is available in most hospitals because it's used for a variety of other purposes. Sometimes it's used in a laboratory setting as a dye looking for certain things, like it used to be used to look at stool samples to see if there were white cells in the stool and what exactly that meant. We often use methylene blue more so in the last few years in critical care, where it's used as a vasoplegic agent. It's occasionally used in surgery and oncology to mark tumors. So I would say most medium-sized hospitals probably have it. You know, if you're in a critical access hospital, perhaps not. If you're in an outpatient clinic, I think it's doubtful. But you know, you can always call and check. It's not as exotic as some of the other things we sometimes get requests for, only because it has multiple uses beyond just use in toxicology.
Another question. Is the blue-gray color some patients develop when taking amiodarone related to methemoglobin?
No, it's a different thing. It's more of a chronic thing, and it's a discoloration due to, I think, the amiodarone itself.
Okay, another question. In a typical benzocaine-induced case in a 3-year-old who arrives to the ED and gets treated within 15 minutes, how long do you need to observe this patient prior to discharge?
There's no easy formula, but they probably can be cleared in about 2 hours or so is our general recommendation. One thing you can always do, and we're happy to do this at the Poison Center, if you want to send somebody home, but you personally, because you're working in a busy emergency department, cannot check on them, you can get the Poison Center involved. Even if you made all the decisions up front, we are more than happy to do a follow-up phone call at whatever interval seems appropriate with folks at home who can ask, how's the baby looking? Are they back to their usual color? Are they, taking their bottle? Are they drinking, eating, and everything else? So I think most cases where the methemoglobin level, is in the 20 or 30%, and you give a single dose of methylene blue, will do fine. There's going to be a few that they don't resolve, and you probably have now identified the small few that have G6PD deficiency. Those definitely need to be admitted and watched for a longer period of time.
Next question. Are there non-pharmacologic causes of methemoglobinemia? I vaguely remember something about severe vomiting and diarrhea leading to this.
Yes. Well, first of all, children up to variable age 3 months, maybe as late as 6 months, have a poor ability to handle nitrates. And so if you live in a farming area where there's nitrates in the soil for fertilizing, and you're getting your water from a well that may be contaminated with runoff from the fertilizer, there's been, handful of cases of young children having essentially chemical fertilizer-induced methemoglobinemia. Other than the nitrates that are abused that aren't pharmaceutical, that can do it as well. There are some cases that just happen from just profound diarrhea as well. And some of those, in retrospect, may be some of these congenital risks where nowadays, where we did a little bit of genetic testing, we might find some of these people that have methemoglobin M or these other congenital deficits of NADPH, methemoglobin reductase, which are rare enzymatic deficiencies that are, you wouldn't know you had them until you got a drug that produced methemoglobinemia.
Thank you. I'm not seeing any other questions in the chat, but we can give it just another moment if anyone has any final questions.
Yeah. Well, I appreciate everyone joining in, and if anyone has any individual cases they want to put in the chat or talk about, that I would be happy to comment on. For those of you, again, I encourage you to call the Poison Center for these type of cases or for any pharmaceutical exposure that you have questions on. We are available all the time. Something about this, you can answer that one, something about closing the certification or something like that.
Yes, if you have any questions about claiming CE, please go to the website listed on the slide. I'll mention as well that the slides and recording will be posted on the Pediatric Readiness Program website, and I'm going to put that address into the chat. I want to thank also Dr. Horowitz for your time today, and thank you everyone for joining. And it looks like we have maybe one last question that came in. Or maybe not a question.
Yeah, a comment. Yeah, from Miles. Thanks, Becca. Chloramine in hemodialysis filters. Sometimes chloramine gas can be generated by the small amount of disinfectants used in certain types of water. And that has happened with, I think, older style hemodialysis, where the chlorates that are generated and chloramine that are generated can induce methemoglobinemia. There were episodes of chlorates, which are different than nitrogen, so that's a completely different substance, inducing methemoglobinemia. There used to be in some match heads as well, and people who like match heads sometimes got methemoglobinemia. Why they would do that, I don't know, but people and kids will do the darndest things, as they say.
Well, thank you, and thank you everyone for joining today. Our next education session is scheduled for May 12th at 8 a.m. Information about that will be sent out in advance and posted on the website. Everyone have a great week, and we hope to see you at the next session.